new case. We'll keep 60, we'll make it a woman, a bleeding colonoscopy, positive for sigmoid lesion, non-obstructing on scan, CEA10 on scan. There's about a 2 centimeter liver lesion, PET positive, only disease. All right? So, Rich, you get first. What day's your clinic? What day's your clinic?
Thursday.
It's Thursday, so what are you going to do? It's 4:30. That's when the new patient shows up.
So I know the surgeon's cell phone.
Yeah.
And he's just down the hall.
So this is an operate first.
Right. So I like the notion of operating first on patients who are operable, because I convince myself that it's easier to eradicate micrometastatic disease than gross metastatic disease. And I would like to get surgical debulking of 99% and then clean up later.
So all we've got is data if you give chemo first that it's prognostic, that if they respond. So, and I'm sort of with you on this. I'm like, get it out and come back to me later.
Well, it's nice to know you're with me, John.
Okay.
All right.
Where are you with this?
I tend to resect if it's resectable and save, use the chemo more if it's borderline, or it would change the surgical outcome. But one of the problems with somebody who's just got a 2 centimeter lesion and it's easily resectable, if you treat with chemo first, they might not be able to find it.
Okay. Yeah, exactly. Let me make it hard. Let's make it a rectal tumor. 6 centimeters from the anal verge, one isolated 2 centimeter liver lesion.
Even with the first one, the challenge is sometimes in your setting, you can have the surgeon to operate on within 2 weeks. In the community setting, sometimes that can go up to 2 months. So we're not going to watch these patients doing that.
Same with me.
I personally like as well to test in vivo the response. You can get the systemic treatment in upfront. The challenge is you don't have the KRAS, NRAS, BRAF results as well. So for all those purposes, I would line up systemic treatment. And with rectal primary, still the same, I would go. Now, the challenge is when you finish your induction chemo and you want to go with surgery, I would take out the macroscopic disease first, because we don't want to do, let's say it's a low rectum, to make it even more complex, 5 centimeter. You don't want to do chemo radiation and do like the standard management of the rectal primary and delay further your liver treatment. We've seen it in the past where we come back to treat the rectum, and by the time you're finishing treating the rectum, now they reprogressed in the liver or in the lung. Of course, we know that there is a big part of these patients are gonna recur, but it's a curative intent treatment.
Yeah, I think it's still a clinical question that's out there, but chemo alone for rectal cancers is certainly emerging, and I'm trying to convince our multidisciplinary gang that if they had a nice response, why do I need to then do chemo RT? Because pelvic RT has major implications, particularly for the younger folks. So I tend to agree. So now the hard part. You took him to the OR.
Unless you're doing a palliative, for palliative purpose, for that. And the palliative, I advocate for the 5x5, the Scandinavian model.
You went to the OR. You found, a T3, one node, and that one liver met. It's all out, and they come back. They healed up. They even, little surgery. It's 3 weeks later, 4 weeks later. CEA1, and they look great. Now what do you do?
Adjuvant therapy with Folfox, aspirin, vitamin D, and exercise.
All right. Same?
So
what do you tell that patient the risk of cure, the chance of cure is?
So if you look at the Fong criteria, that patient had a low CEA, they had only one positive node, they had a single small lesion, and they had synchronous disease. So they get 1 point on the Fong score. And so I would tell that person that their chances of cure with no further therapy is probably somewhere around 50%. And that by giving adjuvant therapy, we don't know exactly how much better we're going to make it, but we believe that it's going to improve the chance of cure.
So they had surgery first, and then
I would tend to go with 5FU yet.
I would go with adjuvant Folfox. I think that's the
no biologic. Anybody giving a biologic?
Well, if this case is a particularly good one, but if they had more liver disease, it was maybe borderline resectable. I would at times give bevacizumab in that setting as well.
So cytostatic Bev, if you look at CLA.
Well, I
Maintenance
think
therapy.
we,
Right.
you
Well, it
know,
is.
Yep.
I think we know that the response rate's higher. I think we know that that in some studies it's improved the survival. And what you're doing at this point is treating a high risk of metastatic, subclinical metastatic disease. In your stage 3 trial where it didn't work in the NSABP, it worked for a while it was on, but the numbers are so much different than when you're talking about your average liver met resection, which has about a 25 to 30% cure rate, which means you have a 60 to 70% recurrence rate. I think in that situation, bevacizumab may improve the outcome. And if they had metastatic disease, I think you can give it.
What'd
I
you give
agree.
pre-op? What'd you give pre-op?
Because since I gave systemic chemotherapy up front, it's going to be with a biologic because it's stage 4. And post-operatively, I tend to document this as a post-operative treatment rather than adjuvant. Of course,
Yeah.
it's semantics.
Right.
I try
No,
to
but
keep
the
the
biology
biologic.
is different.
Yeah.
Yeah, so
I
how
try
do
to
you-
keep the
how do-
biologic for, for the,
mean, we
but
already
the
talked-
cytotoxic 6 months. Of
We already
follow-up.
talked about stage 2 and stage 3 having very different biology, different molecular characteristics. I mean, stage 4 is stage 4. It's different again. So,
Absolutely.
and additionally, the numbers in terms of the clinical trial outcomes are much more in favor of using it because in the stage 3, you need a much bigger trial to avoid a false negative.
I really don't know what to do in this patient. I mean, I have the same instincts as you all about, I want to give some chemotherapy. I don't want to lose my adjuvant benefit. But then the only study we've got is the RTC study, the Norlene J study, which is small, dirty study, but didn't show the adjuvant effect. And so when I'm thinking about, and in colon, why doesn't irinotecan and the EGFR and all these drugs work in the adjuvant? I wonder if we're hunting a different thing, and that a seed is what I think 5-FU and ox is probably killing, but seeds are little crunchy things that can you don't have a garage that can stay in a garage over the winter and be a plant later, whereas a small plant is a different thing. They have the same genetics and all, but they're different things. And I think we have an adjuvant effect, but so far we haven't demonstrated an adjuvant effect in metastatectomy patients. And we only have the one study.
in
So I
the-
believe in cytotoxics
Yeah.
for adjuvant therapy because I don't think it matters that you put cells into dormancy when your goal is cure.
Right.
And in fact, it may hurt you rather than help
Maybe,
you.
maybe.
The other thing I was going to say is on the Norlene J study, overall, with the intent to treat analysis, there was no survival benefit. But if you look at the people who actually landed up being operated upon and were actually surgical candidates, throwing out the ones who had occult disease, it did show a benefit. So it was kind of close. And
3 or 6 months of Folfox.
Just the right amount.
Just the right amount. How about you?
Well, today I think I would give everybody 6 months who
6
wasn't
months.
on the trial, the
Correct.
adjuvant trial. But
Quick
the
to
good
stop the
news
ox
is,
if you hit
the-
neuropathy.
but yeah, I mean you can if I drop the oxaliplatin if I'm concerned about toxicity at 3 months. But I think that we'll soon have the answer to that, and we'll know if there is equivalence. Because of the large number in the meta-analysis.
But don't you think
the
it's going to
idea
be different for different patients? Yeah. That T3B patient with 5 positive nodes may need a little bit more of that stuff in order to get rid of that last
Well, maybe,
residual
but
cell.
I think we'll have, with 12,000 patients, I think there'll be some pretty good subset analyses that'll give us a better handle on that.
Quick twist to the case, and we'll do one more case after that. 6 liver mets, primary in place. You decide to give pre-op chemotherapy. Nice response. Path surgery now, like, I don't know, 2-3 months after initiating treatment. Used Bev, and lots of necrosis in the liver, but still some residual disease, but sort of, the divot, that there was cancer there. Nice downstaging of the primary. CEA1, healed up. Now what do you do? It's had, 2 months, 3 months of chemo.
I finish
R-
out 6
R0
months of
resistance.
chemo.
6 and stop?
6 and stop.
Yes, I agree.
I agree.
So I'm going to treat that patient forever. I'm going to treat that
Really?
patient as inevitably metastatic and
But if they're
consider.
inevitably metastatic and you get them down to no disease,
That's what I don't know what to do. So if there was evidence of disease, of course I would give maintenance at that point, like we discussed before. So the question is, this just subclinical? I don't know. So I don't know what to do.
So do you
Fortunately for
ever
the patient, unfortunately for you as a treating physician, because this is the one what we don't know.
Yeah, we don't know.
do you ever stop chemo?
Yeah.
So I do too.
Yeah.
It depends on what the bulk of disease is, what the pace of disease is, what the patient's goals are. But in some patients, I'll say, okay, I'm going to keep seeing you every 2 months. I'm going to keep scanning you every 2
Right.
months. I might let the disease grow a little bit, if you're okay with that. But we're going to give you a break.
That's my approach too. I mean, you're gonna. It's much harder to continue therapy where there's nothing to follow. So you're going to give them a break at some point. I'd rather give it earlier. There are some people where on the next scan, 2 months later, you're going to have to restart. But
Right.
there are quite
They
a few
still have
people
2
that'll
months
go.
off.
Would you?
Yeah, there are quite a few people that'll go 6 months or to a year before
Right.
you need to restart, and
Question-
some that you'll never need to
The
restart.
question, if there is reactivation of disease only in the liver, I think these are good cases for maybe radioembolizations
you
or
start
doing
getting
case
that.
like what we were talking earlier to avoid systemic exposure.
But I think one of the criticisms that I put on us is that we've failed really to be able to design clinical trials for that metastatectomy patient. And I think in
Yes.
large part because both of the scenarios I just described would be eligible, and they clearly are very different patients. And so and they're not common, there's not routine patterns. So do we bundle them all in and do studies of new approaches and new medicines, or do we just sit and wait? And I struggle
So you
with that.
remember, we tried very hard to
I
get
remember.
a cooperative group trial looking at
Mike Chody's,
serial
yeah.
non-curative surgeries in patients with limited metastatic disease. And I still believe that that's being done all over the world.
yeah.
Yeah.
And that it impacts natural history.
I
But
think it
we
clearly
lost the opportunity to study it.
So are we debulking, and it's because imaging's better and surgeons are better and recovery's better, and so it's worth just getting out what you can?
Well, you're just a debulker by nature,
That's right. That's
my
right.
friend.
I know.
there is an underlying
But we all learned that if you didn't do surgery unless you were going to get it all, right? So we've really changed those rules, I think. with all-
But it's a separate biology that is imposing itself
is.
to us. And I
It is.
think one, for research purpose, maybe this is the subgroup that it's worth checking the immuno-oncology, the checkpoint inhibitor as opposed, you debulk as much and you use your checkpoint inhibitors, especially if they are MSI high or not. Maybe there we have an opportunity to change the course of the disease. Of course, I think that will be an interesting trial to do.
So I look at it a little differently. I think that for most cancer, you cannot cure metastatic disease. Breast cancer, for example, ovarian cancer, they operate on a lot, but you can't cure it. Colon cancer, 25% at least will be cured with metastatic disease if you get an R0 resection. And in the more modern series, it's like 40 to 50%. So with the right preoperative treatment, with the right surgery, you're getting to cure a fairly substantial number. And that reflects a different biology where there is a liver predominant hepatic tropism for the tumor that shows you that there's a group that doesn't have metastatic disease elsewhere. And I think the surgery is removing the resistant clones, so that's why you get this cure rate.
Last case.